Hi, good afternoon, Dr. Hui, Dr. Gan, Dr. Azhani, and Afiq. Dr. Azhani, do you want to test your slides to see if it works first before we actually start?
Yeah, sure. Just hold on. Let me try
Yeah.
and share my screen. Um, okay. Can you see the slide
Yep.
changing?
Yeah, can.
Hang on. Okay, yeah, I'm just trying to minimize one. Okay, hang on. Okay, how do I do this? All right, fine. Sorry. There. That's all right.
Yeah, that's good.
Great, great.
Okay, thank
Cool.
you. So we will start shortly at 3 o'clock.
Yep, no worries.
Okay.
Do you want me to say a few words and then just at the beginning?
Yeah, sure, Dr. Hui, no problem.
Yeah, I'll be very short.
Okay. Hi, Dr. Hui. Would you like to start now? It's 3 o'clock.
Chairman want to say anything?
Sorry?
Does the chairman want to say anything?
Oh, hello, Dr. Hui. Yeah, I think Dr. Hui, you can start first. Then after that, from there, I
All right.
continue
All
to
right.
introduce Dr. Azahani.
Right.
Yeah.
So we'll start now. Yeah. Good afternoon, everyone. I'm glad to say a few words about the College of Physicians Malaysia. The college is a professional body registered under the Societies Act with the Registrar of Societies. It comes under the umbrella of the Academy of Medicine of Malaysia, and all physicians who join the academy automatically become members of the college. We are now housed in the new academy building, and the address is Unit 3.7, Level 3, Medical Academies Malaysia, number 5, Jalan Kepimpinan P8H, Precinct 8, Putrajaya. The college is active in education and training and runs the MRCP examinations for the parallel pathway. It is also the voice and advocate for physician causes. Our annual scientific congress will be held this year at Hospital Al Sultan Abdullah, UITM Puncak Alam, from 22nd to 24th November 2024, and will be officiated by HRH Sultan Nasrin Shah. Apart from the scientific program, there will be quiz sessions for the Kukalin Club, conferment of fellowship and lifetime achievement awards, and the Dato Lim Ki Jin oration. Hope some of you can attend. Thank you.
Okay, thank you very much, Dr. Hui, for the introduction about the College of Physicians. So a very good evening to everyone in attendance. Welcome to the third week of the Nephrology Month, and the topic for today is the kidney diseases in pregnancy. So we're very privileged to have two very esteemed guests with us today, our chairperson, Dr. Gan Chai Chung, and our speaker for today, Dr. Azhani Akmar from Hospital Serdang. So before we move on, let me introduce our chairperson, Dr. Gan Chai Chung. He's a consultant interventional nephrologist, physician, and senior medical lecturer at the University Malaya Medical Center. And he is basically a background about him. He graduated in he graduated his MBBS from AIMS in 2010 with first class honors, and then subsequently obtained his MRCP UK in 2014 and proceeded to do his fellowship in nephrology and completed it in year 2020. He then did his fellowship in interventional nephrology in Singapore and also in Japan. And he was the first in Malaysia to actually secure the ISN Interventional Nephrology Scholarship to Japan. He has published many articles and produced many publications and researches, namely the Diamond, EMPA Kidney, so to name a few. Dr. Gan is very interested in teaching, and he also heads the clinical nephrology services in University Malaya at the moment. So without further ado, Dr. Gan, the floor is yours.
Thank you for kind introduction, Dr. Vidya. First of all, thanks for your kind introduction, and thanks to the organizing committee for inviting me. But just to rectify, I'm not the head of SWIS. I'm actually spearheading the interventionist services in collaboration with vascular surgery and also IR. Yeah. So okay, I'm honored and glad to introduce one of our esteemed colleague. She's none other than Dr. Azhani Akmar Azhar. She's currently the physician and nephrologist at Hospital Sultan Idris Shah, Serdang. She had her undergraduate study MBBS completed with flying colours, University of London, in year 2007. And she pursued a career pathway into internal medicine via the Master in Internal Medicine at University of Malaya from year 2012 to year 2016. She then subspecialized into nephrology from year 2019 to year 2022. She was honored with 2 Excellence in Service Awards, and she was invited in as a speaker in several established social media, including Malaysia ini. She also has several publications and e-poster presented in the nephrology world. So let us invite Dr. Azani to shed us some lights into the topic of the kidney disease in pregnancy. And for audience, please don't hesitate to put up your questions, your burning questions at the Q&A sections. The floor is yours, Dr. Azani.
Right, thank you, Dr. Gar, for the kind introduction. Thank you, Dr. Vidya. And I would like to thank the College of Physicians for this invitation to give a talk for today. So today's talk would actually be kidney disease in pregnancy. I mean, something which I'm actually very, very interested in. So considering the variety of our listeners today, I thought it would be good to actually share how we manage pregnant women who has underlying CKD in our day-to-day practice. So for the purpose of this talk, when we mention patients with kidney disease, so it would actually involve patients with CKD as per category classification, regardless of the underlying disease, as well as patients who actually have glomerular disease with normal serum creatinine or otherwise. So this would be my outline of the talk. Admittedly, it's going to be a bit wordy, quite a lot of diagrams, but don't actually worry about it so much if I go too fast, because I will leave my email address towards the end, so that, you know, if you're like, I will email the slides to you later on. So again, this is the outline of my talk. And just to show you the burden of chronic kidney disease globally in 2022. So it's actually basically 1 in 10. So it's estimated to have we have 843 million patients living with chronic kidney disease as per 2017. And it's actually more prevalent, if you can see in the picture here, women. So it is actually quite prevalent in women. And as you know, CKD prevalence increases year by year, and definitely we will see more and more women with childbearing age with underlying CKD in our clinic follow-up. So while we don't actually have local data in Malaysia, we do know that CKD affects up to 6 and 9% of women of reproductive age in high and low income countries, and approximately 1/3 of whom have stages 3 to 5 CKD. And this prevalence is predicted to rise in the future because of increasing maternal age as well as obesity. And just to go through very quickly what anatomical and physiological changes we have in pregnancy. So we know there will be increase in size of the kidney by 1 to 1.5 centimeter in length and up to 30% in volume. And there will be dilatation of the ureter and pelvis, which is more prominent on the right side, up to 6 weeks postpartum. There will also be urinary stasis of at least 20 mL of urine in the collecting system. So this is actually why, you know, we actually treat pregnant ladies with asymptomatic bacteriuria, because of this fact, they are at high risk of pyelonephritis. So again, there will be increased renal blood flow in 50 to 70%. By 50 to 70%, especially in the first 2 trimesters. GFR will increase by 50% and it peaks at the 13th week. There will also be physiologic reduction of urea and creatinine. So this is just a table to actually summarize all the adaptive changes during pregnancy. So how do we measure kidney function in pregnancy? So basically, we actually use serum creatinine. Serum creatinine-based formulas are actually not accurate in calculating estimated GFR in pregnancy. So creatinine clearance measured in a 24-hour urine collection remains the most practical test to estimate GFR during pregnancy, although it is expected to overestimate GFR by 10 to 20%. Unfortunately, I know it's actually labor intensive to actually measure creatinine clearance in pregnant ladies. So how do we actually monitor their kidney function? Is recommended to actually use serum creatinine concentration and monitor its strength throughout pregnancy itself. So in terms of quantification of proteinuria, 24-hour urine protein measurement remains the gold standard. Although there is practices and recommendations which actually say they do recommend quantification of proteinuria by using urine PCR or urine albumin creatinine ratio. So for how do we manage patients of childbearing age with underlying chronic kidney disease or glomerular disease who actually wish to conceive. So, basically all female patients of reproductive age should have the discussion regarding fertility issues with regards to their underlying medical condition and the effect of their medications on fertility. It's a known fact that fertility is reduced in CKD patients, right? The more advanced the stage is. However, pregnancy can occur in all of these stages. So what do we need to tell them? For pre-pregnancy counseling, so if the patient wishes to not conceive, or they are actually unsuitable at that point of time because of their, well, basically the activity of the disease, their glomerular disease, or the stage of their chronic kidney disease. So we need to actually counsel them on contraception. All right. So because risk of adverse outcomes to all unplanned pregnancy is high in all CKD stages. So you can either use progesterone-only methods, which is safe and effective in women with CKD. And we know this, that barrier methods have high failure rates with typical use. So for those who actually wish to proceed with pregnancy, we need to remove or substitute any teratogens before conception. Consider risks and benefits to remaining on ACE inhibitors until conception. A lot of patients, especially who have underlying hypertension or actually have proteinuria, they will be either on ACE or ARBs. And we need to ensure the disease or transplant stability before the conception. So when is the perfect timing for pregnancy? When is the optimum time? So basically, the disease needs to be quiescent for between 6 to 12 months for patients with glomerular disease. If the patients have GFR, pre-pregnancy GFR of more than 60 mL per minute, that's the best time. Proteinuria needs to be less than 1 gram per day. If the GFR is less than 30 mL per minute, we strongly suggest for them to wait until kidney transplant has occurred. So, what about patients on immunosuppression? So basically, they must be on stable dose of immunosuppression. This will be especially for patients post-transplantation. Need to explain the risk and benefit ratio of switching the immunosuppression. We need to switch to non-teratogenic drugs pre-conception, observe the kidney function after the switch, then subsequently decide whether the patient can actually undergo pregnancy or otherwise. So medications of mycophenolate mofetil, mTOR inhibitors must be stopped at least 6 to 12 weeks before pregnancy. Medications such as azathioprine and CNI are actually safe. Hydroxychloroquine is actually usually used for patients with underlying lupus, so must be continued. Prednisolone dose must be stable and minimal. What about other issues? So to assess other risk factors, smoking cessation, diabetes control, weight reduction, hypertension control, and of course we need to understand a woman's wish to plan pregnancy and the psychosocial factors affecting it. So for those, I mentioned just earlier that when women who has GFR less than 30, we actually discourage them from becoming pregnant. However, it's basically still the right of the patient to actually choose whether they want to proceed with pregnancy or not. However, if their GFR is less than 30, we need to discuss the potential need for dialysis in the peri-pregnancy period. So how do we risk stratify patients with kidney disease? So key pre-pregnancy factors to predict pregnancy outcomes would be the degree of reduction in GFR or elevation in serum creatinine, presence of coexisting hypertension, as well as the amount of proteinuria. So, even patients with who actually have CKD stages 1 or 2, they are associated with a higher rate of preeclampsia and perinatal mortality, preterm delivery, and small for gestation age rates. And the development of superimposed preeclampsia appear higher in women with the preconception creatinine values of less than 124 micromole but greater than 80 micromole in early pregnancy. Even those with normal GFR but state positive proteinuria and with one or more risk factors for preeclampsia are at higher risk. So those patients with serum creatinine greater than 123 micromoles per liter, particularly when accompanied by hypertension, heavy proteinuria, they would have a higher chance of preterm deliveries and maternal complications, including the loss of kidney function. And women with pre-pregnancy CKD stages 3 to 5 and a urine PCR of greater than 100 milligram per millimole, that's about 1 gram a day, before pregnancy or prior to 20 weeks gestation, they are more than twice as likely to deliver a baby weighing less than 10 percentile compared with women with CKD and less proteinuria. So how about the severity of hypertension? So as we know, pre-existing hypertension is associated with significantly higher risk for adverse pregnancy outcomes than in the general population and in pregnant women with CKD. In a contemporary cohort of women with CKD stages 3 or higher, chronic hypertension was the strongest predictor of preterm delivery before 34 weeks and was associated with a greater decline in maternal function in pregnancy. In terms of proteinuria, it can be detected first during pregnancy, meaning that it was not known prior to pregnancy whether the patient has proteinuria or otherwise. So it may reflect either pre-existing or new onset kidney disease. Although we have to say that most common cause of nephrotic range proteinuria in pregnancy is preeclampsia. So women with pre-pregnancy CKD stages 3 to 5 will urine PCR more than 1 gram per day before pregnancy or prior to 20 weeks gestation. I think there's a duplication of the slide. Sorry about that. Right. So basically, in terms of proteinuria, a definitive diagnosis can usually wait until after pregnancy because nephrotic range proteinuria per se does not alter the natural cause of pregnancy or fetal survival as long as it is not associated with significant kidney failure or hypertension. But there are exceptions. If they actually have either serology evidence of lupus nephritis or profound hypoalbuminemia. This is to actually just show you the maternal and fetal outcomes as published by Abraham et al. As well as Piccoli et al. If you can see the risk of maternal and fetal outcomes increases as the CKD stage progresses from 1 to 5, stage 5. So this is actually a useful table when we actually counsel patients, but basically this shows you the maternal kidney outcomes according to the pre-pregnancy CKD stage, as well as fetal outcomes according to the maternal pre-pregnancy CKD stage. And as you can see, the risk is as early as stage 1 to 2. So again, this is just a diagram to actually show you the possible adverse maternal and fetal outcomes which can be used to actually counsel patients during their pre-pregnancy period. So again, this is just a summary of the risk stratification for patients with underlying kidney disease. So it's divided into 3. Either they have stable GFR with CKD clinical stage 1 or 2, then you have reduced GFR with stage 2 to 3, or deteriorating GFR with CKD stage 4 to 5. So basically, we can actually see across the categories. The most important thing, again, as mentioned, is the control of hypertension, as well as the amount of proteinuria that you actually pre-pregnancy proteinuria. So going into antenatal care in CKD patients. So the subsequent slide, basically where there is a level of evidence quoted, the recommendation is actually taken from this clinical practice guideline of pregnancy and renal disease published by BMC Nephrology. So general management, of course, pregnant patients with underlying CKD or glomerular disease needs to be managed by a multidisciplinary team for pregnancy counseling and optimization. And they require routine antenatal care in addition to specialist input. We have to refer them to specialists in fetal medicine, especially if the mother and baby is exposed to teratogenic drugs in the first trimester. Fetal growth and well-being assessment scans needs to be done in the 3rd trimester. And these patients need to be screened for gestational diabetes, especially those who are taking prednisolone or calcineurin inhibitors. So for preeclampsia prophylaxis, it is suggested that we offer them low-dose aspirin to reduce risk of preeclampsia. For kidney donors as well, we should offer them aspirin between 75 to 150 milligrams to reduce preeclampsia risk. And this should be prescribed from 12 weeks gestation onwards. There's actually a lot of evidence in terms of use of aspirin in reducing the risk of preeclampsia. So a Cochrane review in 2019 states that administering low-dose aspirin to pregnant women led to small to moderate benefits, including reductions in preeclampsia, preterm birth, the baby being born for small for gestational age, and fetal neonatal death. And the US Preventive Services Task Force find that there is moderate certainty that there is a substantial net benefit of daily low-dose aspirin to reduce the risk, as mentioned earlier. So how about blood pressure management? We should actually target blood pressure less than 135/85 millimeters mercury, and this goal needs to be documented in the healthcare record. And we should continue antihypertensive treatment in pregnancy unless systolic BP is consistently less than 110 millimeters mercury, or diastolic BP consistently less than 70 millimeters mercury, or there is symptomatic hypotension. So in pregnancy, it is recommended to use labetalol, nifedipine, and metaldopa in pregnancy. Do not use ACE inhibitors, ARBs, and diuretics. So this is basically just a table to indicate, the different antihypertensive medications which is available, and what the doses, as well as the potential side effects in pregnancy. So it's a big question actually, especially for us in nephrology, when we get referrals from the ONG department, pregnant lady who comes in with proteinuria. So our first question will actually be, is it preeclampsia? Because as mentioned, the most common cause of nephrotic range proteinuria in pregnant women is actually preeclampsia. So it may not be that very clear at the beginning itself, but basically for preeclampsia diagnosis in women with CKD, right? So for women without chronic hypertension, it should be diagnosed as per eclampsia diagnosis. So those in women with chronic hypertension, there is no diagnostic threshold, right? If they have severe BP of systolic of more than 160 or diastolic of more than 110 millimeters mercury, or an increase in treatment requirement to control the BP, that might be an indication, possibility of preeclampsia. So in terms of proteinuria, in women with non-proteinuric CKD, the diagnosis would be as per preeclampsia, as per usual diagnosis of preeclampsia. For women with proteinuric CKD, there is no diagnostic threshold. Some research cohorts, they actually say it is more than 100% increase, and unit PCR of more or equivalent to 0.3 milligram per milligram, or more than 30 milligram per millimole. So in terms of serum creatinine, so for women with CKD and preserved excretory function, the diagnosis of preeclampsia is as per usual. And for women with CKD and abnormal pre-pregnancy function, there is no consensus in the diagnostic threshold for change in creatinine. Could be more than 50% increase within 7 days, which is used in previous research cohorts. So, so once preeclampsia is actually diagnosed, of course, there might be some indications for delivery for patients who have an underlying CKD. Some of it include gestation of more, or once they reach 37 weeks, the inability to control blood pressure, deteriorating kidney function, if the patients have any neurologic abnormalities, worsening thrombocytopenia, increasing liver transaminase levels, if there's any concern in failure of fetal growth, or if there's evidence of reverse or absent end diastolic flow on cardiotopography. Right. Talking about thromboprophylaxis for pregnant women. So women with nephrotic range proteinuria should be offered thromboprophylaxis with low molecular weight heparin in pregnancy and postpartum period, unless there is a specific contraindication, including risk of labor or active bleeding. So non-nephrotic range proteinuria in pregnancy, is a risk factor for thrombosis, and thromboprophylaxis with low molecular weight heparin should be considered in the presence of additional risk factors. So RCOG Green Top Guideline number 37A, published in 2015, actually have quite a nice table to actually as a guide on when to actually start thromboprophylaxis. Would you just like to actually mention that the risk factors would actually include obesity, age more than 35, priority of 3 or more, the patient is smoking, any evidence of varicose veins, current preeclampsia, any reason for immobility, if there's any family history, low risk thrombophilia, multiple pregnancies, or if patient became pregnant via IVF or assisted reproductive techniques. So for patients who have anemia in pregnancy, so we can give parental iron if indicated, and if there's indication as well, we can give erythropoiesis stimulating agents. This is especially for patients who are on dialysis. So it's recommended to actually give vitamin D supplementation in those who are vitamin D deficient. So meta-analysis actually demonstrates that oral vitamin D supplementation is associated with reduced risk of preeclampsia, low birth weight, and preterm birth. And we can offer replacement anti-serum calcifediol is more than 20 nanogram per ml or more than 50 nanomole per liter. We need to discontinue calcium mimetics in pregnancy, discontinue non-calcium-based phosphate binders. So how about those patients who first present with proteinuria in pregnancy itself? I mean, as said, is this preeclampsia, or does the patient have underlying glomerular disease which is picked up during pregnancy itself? So nephrotic syndrome is diagnosed when proteinuria is more than 3 grams a day and serum albumin is below the lower limit for gestational age. And diagnosis of glomerular disease in pregnancy needs to be guided by other clinical features, for example, hematuria, any extrarenal manifestation, as well as biomarkers. So do we actually do renal biopsy in pregnant patients? So kidney biopsy needs to be considered if there is progressive decline in kidney function, if severe proteinuria despite pregnancy safe immunosuppression, and it can actually interfere with pregnancy outcomes. Kidney biopsy may be needed to establish a diagnosis, and if treatment needs to be started during pregnancy itself. So kidney biopsy is safer in the first trimester as bleeding risk increases beyond 22 weeks gestation. In later pregnancy, if a kidney biopsy is required, it has to be done in the lateral decubitus position. For patients with aspirin, needs to be withheld 5 to 7 days before kidney biopsy. This is actually chart again just to show you how to actually monitor patients who have underlying glomerular disease in pregnancy. If they actually have isolated microscopic hematuria, we can monitor EGFR and proteinuria. All right, so if patient has proteinuria with or without acute kidney injury, we actually have to assess the degree of proteinuria, if there's any pre-existing hypertension, any other extrarenal manifestations, and based on that clinical assessment, we send targeted investigations. All right, so in the event of worsening kidney function, if the kidney biopsy will modify treatment, then kidney biopsy is actually recommended. If kidney biopsy will not modify the treatment, then the treatment is actually just symptomatic, and we can actually give a short trial of pregnancy safe immunosuppression. So I would just like to discuss specific conditions for in pregnancy for patients who actually have chronic kidney disease. So one of it is pregnant patients who are already on regular dialysis. So there have been significant improvements in outcomes of pregnant patients who require dialysis during pregnancy over the past 2 decades, with fetal survival rising from less than 50% to almost 85%. And pregnancy rates have also risen, with a 71% increase in delivery rate among women of reproductive age undergoing hemodialysis. This is as reported in the United States between the years 2002 and 2015. So improved outcomes have been associated with more intensive HG regimens and advances in neonatal care, which enable survival for premature and growth-restricted infants. Women of childbearing age undergoing dialysis have low rates of conceiving, but increments in dialysis dose such as nocturnal home HD appear to be associated with increased fertility. Therefore, we have to remember women of childbearing age on maintenance dialysis, they can get pregnant, although fertility rates are low. However, this group of patients, if they do not wish to conceive, they should have access to safe and effective contraception. So how about those who require dialysis initiation for progressive CKD? As mentioned before, patients with pre-pregnancy GFR or less than 30 mL per minute have this risk. So dialysis should be commenced in pregnancy for the standard indications of hyperkalemia, acidosis, uremic symptoms, or fluid overload. However, it's more common to initiate dialysis in pregnancy because of the potential fetotoxicity of urea. So, optimal serum urea concentration at which dialysis offers benefit in pregnancy is unknown, and practice varies from the routine commencement of dialysis at maternal urea of more than 17 millimoles per liter to dialysis when it's consistently more than 20 millimoles per liter. So in progressive kidney disease, we have to consider risk, benefits, and logistics of hemodialysis in pregnancy with the risk of preterm delivery before dialysis initiation if the gestation is approaching or exceeds 34 weeks. So the goal of dialysis intensification is to achieve better clearance of uremic toxins, increase in ultrafiltration rate, reduce risk of high blood pressure and cardiac hypertrophy, and improve endothelial function. So if patients on dialysis who get pregnant, if patients are on patients are on peritoneal dialysis and they become pregnant, it is a usual practice to actually switch these patients to hemodialysis throughout their pregnancy. So this is actually a summary of management of pregnant HD patients. So the dialysis dose is recommended to be at least 24 hours of dialysis per week, with goal of blood urea nitrogen of less than 14 milligram per deciliter. That's basically urea of about less than 14. So dialysis composition needs to be adjusted. For serum bicarbonate, probably use 25 milliequivalent per liter to maintain the serum bicarb of between 18 to 22. Right, so we need to adjust the calcium dialysis itself with regular monitoring of calcium phosphate levels. Try to maintain normal serum sodium levels as well. So in terms of supplementation, so for vitamins, it needs to be double dosed. Folic acid, give folic acid 5 milligrams per day. Diet needs to be unrestricted as they are on very regular dialysis, and protein intake, we have to actually consider on increased protein intake between 1.5 to 1.8 gram per kilogram per day, because more frequent dialysis results in more protein loss. So in terms of dry weight, these patients need to be assessed weekly, and we have to actually adjust with the increment of 0.5 kilogram of body weight per week in second and third trimesters. So in management of anemia, we increase the erythropoiesis-stimulating agent and iron requirements as per required, with a target of hemoglobin of 10 grams per deciliter. In terms of hypertension, we try to target post-dialysis BP of 140 over 90 millimeters mercury. Preeclampsia prophylaxis again, we use low-dose aspirin. For metabolic bone disease, so we need to continue on vitamin D analogs to maintain PTH levels as in general dialysis patients. Oral phosphate binders are generally not required. So going into another group of patients, which are patients post-kidney transplantation. So successful kidney transplantation is an excellent way of restoring fertility in women with end-stage kidney disease. So the optimal timing of pregnancy depends on the individual circumstances of the transplant recipient. So there is a consensus by the American Transplant Society whereby that pregnancy can be planned when patient reaches 1 year post-transplantation, provided that the following criteria are met, which include adequate kidney function, stable immunosuppressive medication dosing in place, no rejection episodes in the past year, no recent infections that can jeopardize fetal survival, no teratogenic medications are taken. So, however, in a study in the US, rates of preeclampsia, gestational diabetes, C-section, and preterm delivery were higher than for the general population in those who conceived within 2 years post-transplantation. So the pre-pregnancy counseling for post-kidney transplant patients, we still need to actually advise them the risks they may undergo during pregnancy. So how about immunosuppression in pregnancy? What is actually safe is prednisolone, azathioprine, cyclosporine, and tacrolimus. CNI concentrations, CNI is actually cyclosporine tacrolimus, so the concentrations throughout pregnancy needs to be monitored, and as well as immediately postpartum, as blood concentrations may change. We need to avoid medications which can interfere with CNI metabolism whenever it's possible. So avoid mycophenolate mofetil as it is teratogenic, as well as sirolimus or everolimus. And these medications need to be ceased 3 to 6 months before pregnancy to ensure clinical stability on an alternative agent, which we usually use azathioprine. How about women who became kidney donors to their loved ones? What about their risks post-kidney transplantation? So it is usually stated that being a kidney donor does not adversely affect future pregnancy outcomes in terms of fetal birth weight, stillbirth, or prematurity. However, recent studies do suggest there may be an increased risk for preeclampsia in pregnancy after organ donation, and some reports suggest that fetal outcomes may also be slightly worse. Existing studies have limitations in their design, therefore pregnancy should not be discouraged in women who have been kidney donors, and these women should be treated as at-risk pregnancies and have a higher number of clinical reviews or more frequent follow-ups, focusing on maternal BP and urinalysis and fetal growth. So aspirin prophylaxis can be considered, especially if they have additional factors for preeclampsia. So this following is actually a summary of medications which can actually be used in pregnancy and lactation. In terms of antihypertension, as mentioned, labetalol, nifedipine, metal-dopa is actually safe in pregnancy. Just like to note that in lactation, metal-dopa is suggested to actually avoid postpartum, because there's a risk of postnatal depression. Usage of ACE inhibitors, it's not safe during pregnancy. However, if post-delivery, these patients need to be on ACE inhibitor, there is safety data available for captopril and enalapril, right? And there is no data for angiotensin receptor blockers in terms of lactation safety. So other medications, immunosuppressant drugs, corticosteroids are actually safe in lower doses. Azathioprine is safe. Cyclosporine, tacrolimus is also safe. Mycophenolate is actually unsafe in pregnancy as well as in lactation. So other immunosuppressants, hydroxychloroquine is safe to be continued on during pregnancy as well as postpartum. Cyclophosphamide is unsafe. There is no clear data for rituximab and eculizumab to be used during pregnancy as well as in the lactation period. Other medications, these are basically safe medications for pregnancy. We have aspirin, low molecular weight heparin, colchicine, iron and erythropoietin. There's unclear data for allopurinol. As for lactation, aspirin, low molecular weight heparin, iron and erythropoietin is actually considered safe for lactation. I've actually come to the end of my talk. These are my references. Thank you very much for listening, and my email address is included here in the slide. If ever after this you're interested to get the slides, I'll be more than happy to email to you. Thank you very much. So I would pass it back to Dr. Gan.
Thank you very much for your comprehensive talk, Dr. Azmi. From pre-pregnancy, during pregnancy, and post-pregnancy with a patient with CKD is not an easy task to do. Such a broad and full of burning questions that one physician will face when a patient got pregnant in CKD, what to do. and what medication to avoid. I think Dr. Hasani has laid out very clearly on what is the medication to avoid, to switch, and what is the BP control, and especially on the aspirin recommendation, the measurement of creatinine and urine protein measurement that can reflect accurate kidney functions. Okay, from the floor, I don't see any question yet at the moment. Probably they're a bit shy. So,
sorry, Dr. Gan, there is one question actually at the Q&A box above. Can you see it?
oh, I can't actually see it.
Oh, okay, never mind. I'll just read it out then.
Yeah, thank you.
Hi, just want to check what is the reference range / lower limit of serum albumin during pregnancy. They're wondering if there is a difference or is it the same?
Yeah,
Right.
thanks, Dr.
Sure. Can you hear me? Yeah,
Yeah.
okay, sorry. I'll just share again myself. I mean, there is a table in my slides which I didn't show earlier. Hang on, let me try and share again. Just so that will be easier for you to see. Right, so basically there is serum albumin range in pregnancy according to trimesters. If you can see here, well, we actually use gram per liter. So in first trimester, the range is between 31 to 51. Second trimester is 26 to 45. And the third trimester is 23 to 42. So yeah, that's actually the range in pregnancy according to trimesters.
Okay, thank you. And there is a second question. Post or dialysis BP, how much is required in all 3 phases of pregnancy? Actually, the question is not quite clear. Dr. Azani, can you see the questions in the Q&A box there?
Hang on, let me just try to navigate. Okay, hang on, try to navigate this Zoom. Right, so post or dialysis BP, how much is required in all 3 pregnancies? Okay, basically I don't think 3 phases. I assume it's 3. I mean, all the 3 trimesters. We just recommended to just target post pregnant.
She said pre-dialysis BP.
I see. Well, there is actually no particular cut-off point or threshold of pre-dialysis BP, what is actually okay. But the most important thing I would actually think, I would say, is that these patients would require regular monitoring of BP, meaning that, patients who are on regular dialysis, they always have that pre and post dialysis BP anyway. But if the pre-dialysis blood pressure is persistently very high, which doesn't come down post-dialysis, there may be an indication to adjust their antihypertensives, or even advise them to take antihypertensives prior to dialysis itself, because quite a lot of patients do not take their antihypertensives on dialysis days.
Okay.
I hope that actually answers the question.
Yeah. So thanks, Dr. Vidya, for reading the question. Now I'm able to see the second one. So, as of now, I don't think there's any new question. So probably I've got some question for you, Dr. Asani, if you don't mind.
Sure.
Okay, you were talking about this pregnancy, when to biopsy, especially when we're suspecting glomerular disease concurrently, or a drop in GFR with quite pretty fast, and we have ruled out vein thrombosis, so on and so forth. So, is there any cutoff that you say how many trimester you can actually not recommended biopsy? I don't say can't, but not recommended.
Sure. Basically, we do know the bleeding risk increase beyond 23 weeks of gestation, but there is a recommendation that it's actually safer to be performed before 30 weeks of pregnancy if it is actually required. Of course, how we actually position the patient during the procedure itself will depend on, well, usually, I mean, I think most of us actually do renal biopsy when the patient is actually prone, but with the gravid uterus there, you might need to do it in a lateral decubitus position. Of course, to do that kidney biopsy again, we need to discuss with the patient and actually evaluate whether to get that diagnosis of that kidney biopsy, would it actually, do we need, is there any change of management or treatment which needs to be given to the patient? And if yes, I mean, we need to actually start some form of treatment, then we have to actually counsel the patients of the risk. But it generally suggested that we do it, before 30 weeks of gestation. And I would actually think that, 30 weeks, it's actually quite close to, I think, 34 weeks right now, where I think at 34 weeks, if absolutely necessary, I think our ONG colleagues are quite confident to actually deliver a baby. So if they can actually wait after the delivery of the baby to actually clinch a diagnosis, then we don't need to actually proceed with kidney biopsy.
Yeah, I do very much agree with you. Yes, the always problem is whether the gestation is large enough to obstruct us from biopsy. But we have got our colleagues who are actually quite confident in doing lateral position, unlike us, we do it. But yes, it must weigh be between these, I suppose, the risks and the benefits, and whether is it safe to be done, because we don't want to trigger delivery and trigger some hematoma and actually drop the BP and jeopardize the baby's life as well. We do not have any other questions, so maybe I will just spice up a little bit. In CKD pregnancy, what if the patient has got very severe proteinuria, very bad, like maybe 5 grams or 6 grams, or maybe up to 10 grams? You can't give ACE, ARB. And what is the threshold that probably you I think this topic will be always asking, what is the limit for you to offer termination of pregnancy for mother's safety?
Well, of course, when we talk about proteinuria, other things we actually need to consider as well. Number one is actually the underlying disease. Is this just CKD with proteinuria per se because of as a result of pre-existing diabetes or hypertension, or is there glomerular disease? Because if there is existing glomerular disease, then of course the line of management there may be additional treatment that we actually need to give. But in terms of heavy proteinuria, I think it goes back to, again, number one, I think the questions would be on our mind would be how many weeks of gestation is this patient. Basically, we want to know, when can we deliver the patient. Number two, of course, we already have that degree of proteinuria, which is very heavy. Thirdly, is there hypertension? Is it controlled? Is it uncontrolled? So that also plays a factor plays a role in our decision on how to actually advise patients. In some patients where, of course, as mentioned, there are some patients whom we diagnose glomerular disease de novo in pregnancy. So we've already rolled out preeclampsia, but proteinuria is actually very heavy. If we do any targeted investigations, serological investigations, we don't think this is lupus. We think it might be probably minimal change disease, something which we can actually start treatment without that biopsy. I think it is also an option to actually discuss with the patient and consider the role of short duration of prednisolone to see whether it responds to the medication or not.
Thank you very much for the clear explanation. And we got one question from Dr. Anis Khan again. And her question is, when do you decide termination of pregnancy with patient with HD, I would say? Yeah.
Okay. So now, from our point of view, from the nephrology point of view, the patient being on hemodialysis, that is actually not an indication of termination of pregnancy itself. So then again, because now with monitoring, with support, we can actually support hopefully the patient right up to delivery. So when to terminate or otherwise when patients are on HD depends on the other usual factors. Of course, mother safety is the most important itself, right? So if they have higher risk of preeclampsia, right? Preeclampsia at the beginning itself, blood pressure is very difficult to control, even 20 weeks and beyond. Basically, we think that maternal well-being would be compromised. So that then we have to bring up that discussion of termination of pregnancy. But for patients with HD itself, if they become pregnant, if we monitor the parameters, everything is actually good. Blood pressure control is good. They achieve all the parameters. Fetal growth is actually good. We can support them right until they deliver the baby, so that's not a problem.
Okay, thank you, Dr. Azhani. I think you clearly laid out the indication. Yes, by doing dialysis and the patient have pregnancy is not it's not the indication to have this pregnancy terminated per se. Yeah. And I don't think we have a new question here, and we've got another 9 minutes to go. I've got one burning question myself, even to myself as well, until now. From nutrition point of view, we always advise our patient CKD, low protein, low protein. So how about patient pregnant? How do we go about that? What is the limit?
So, especially patients with, all right, probably a little bit different. Patients, we're talking about patients, there will be difference in terms of patients with CKD and then patients end stage who are on regular dialysis. So I would actually talk about the ones on dialysis first because it's actually simplest. So when we intensify dialysis, hemodialysis, so there will be more protein loss during hemodialysis. So for this group of patients, we would actually need to advise them to increase their protein intake to ensure that baby growth is baby achieves its adequate growth. So for patients with CKD, it's basically stage 1 or 2. I think in terms of protein restriction, whether it's it's extra protein, I don't actually because their kidney function is not really very compromised. I don't know, usually we don't do we actually bring up the topic of restriction of protein at that stage itself. And of course in pregnancy, basically because of the maternal requirement, in general we need to increase our food intake, as we are eating for two, as they say. So I would say that protein restriction for patients maybe CKD stage 1 or stage 2. I think that the advice would be just as per other pregnancies, normal pregnancies. I would think. I'm not actually sure. What are your thoughts after that?
Well, I will let this job to the dietitian, I think. I mean, this and that. Well, I do agree, like CKD 1, 2 in a pregnant lady, I don't think you need to restrict. Of course, the question is always comes to a very heavy proteinuria, and then you're losing protein, and then whether you're going to top up a lot or not, or if too much, and then it makes the progression worsen, this and that. I suppose we need to hit the balance, and always in a patient with CKD in a pregnant, CKD patient in pregnancy, we should actually manage it with a multidisciplinary team approach. Yeah, because we need more brains to actually give a better care to our patient. Yeah. So let's check for the very last time if any new questions. Dr. Vidya, any new question from your side? I don't see.
No.
Yeah. So I suppose if there's no questions, then I think we should wrap up our session for today. And thanks, Dr. Hui, for leading this talk. Thank you, Dr. Vidya, for inviting us, and Dr. Azhani to give us a very brilliant talk today. And I myself also learning. Yeah, I'm towards intervention that did lost to the pregnancy in CKD anymore. And I hope these sessions actually benefits everyone here. And with this, I thanks a lot everyone for your time and speakers' time. And thank you very much.
Thank you very much. Pleasure to be here.
Thank you very much, Dr. Guy, Dr. Azhani, and the participants for joining as well. And we'll see you all next week for another topic in nephrology. So have a pleasant evening, everyone. Thank you.